Hello everyone, and welcome to this evening's webinar. This webinar is to provide an update and information about the effect of COVID-19 on surgical education and training and IMG pathway to fellowship, and this is specifically aimed at supervisors and trainers. So on behalf of the College, Royal Australian College of Surgeons, I would like to acknowledge the traditional owners of the country throughout Australia and recognise their continuing connection to land, water and community. And I extend my respects to their elders past, present and emerging. Tēnā koutou, tēnā koutou, tēnā koutou, katoa to our New Zealand attendees. So welcome, as I said, my name's Adrian Anthony. I'm a general surgeon based in Adelaide. I am a college counsellor and I chair the Board of Surgical Education and Training. So that's where all the specialty boards meet at that particular group to oversee and govern our surgical education and training. As I said at the start, that this webinar is about information sharing, specifically for supervisors and trainers. We've been running a series of these webinars, all looking at how the college is responding to the disruption caused by the COVID-19 on surgical education and training. I have received quite a number of questions before the webinar. So to answer these questions, we have a panel, a number of my colleagues. So I'll introduce Professor Phill Carson. Now, Phill, many of you will know, is a general surgeon based in Darwin. He's also a college counsellor, and he is currently the Centre-in-Chief at the college, which is the role looking after education and training, and he is the immediate past chair of the Court of Examiners. So welcome, Phill. Niell Price. Niell is a paediatric surgeon based in Auckland, and Niell is the chair of the Board of Paediatric Surgery. So welcome, Niell.
Thank you.
We also have another Niell, Niell Boustred. Now, Niell is an otolaryngology head and neck surgeon based in Sydney, and he chairs the Board of Otolaryngology Head and Neck Surgery. A person who you cannot see online today is Stephanie Weidlich. Stephanie is a general surgeon. Stephanie's based in Darwin as a general surgeon there. She's currently doing a rotation down to Catherine, and because of that, the IT connections have defeated us. But welcome, Stephanie. And Stephanie has had significant experience as a supervisor, set supervisor, and in fact is a recipient of an Educator of Merit Award last year. So welcome, Stephanie.
Thank you.
And Julian Archer, certainly not the least. Julian is the Executive General Manager of Education at the college. Now, Julian has professorships in medical education and is a paediatrician as well. So welcome, Julian.
Thanks, Adrian. Good evening, all.
So the format of the webinar is that we have gathered a number of questions already submitted by a number of supervisors and trainers, and we've identified some themes. So we'd like to cover those as best we can this evening. And we thought that we'd take this opportunity to also update supervisors and trainers on a number of projects and activities that the college has been running. So we thought that would be a useful opportunity to do that. Now, if any of you who are in attendance have questions, you can certainly submit them on your question pane on your computers. And as you do so, we'll certainly try to address those as the webinar goes on. The webinar is being recorded, so it will be put up onto the COVID Hub website, or of the college website, I should say. Now, the themes that we identified, quite broad-ranging themes, and probably nothing too surprising. They cover off on the fellowship exam and other types of exams. The second theme is on in-training assessments and progressing trainees. Third theme is on set selection. Fourth theme is on supporting pre-vocational doctors. Fifth theme is on accreditation. And then, as I said, at the end, we will give you an update on some projects directly related to supervisors and trainers. So we'll start off with the first theme, and Phill Carson, I'll ask you the first question. This is about the fellowship exam. I guess the broad question is, the college suspended the fellowship exam early this year, but it has recently announced that it will be conducting fellowship exams. So exactly when are the fellowship exams being held? And also, who will be eligible to sit for the exam?
Okay, thanks, Adrian. So, yeah, so for those who haven't caught up with the dates, the writtens will be held on the 8th of September at multiple venues, all the capital cities except Darwin and Hobart, and Auckland in addition to Wellington. And they'll be done at the what do we call it? Those done in offices, and they'll all be done online. So that's where the fellowship exam has been heading that way for the writtens anyway, fortunately, and there was only one or two that had the alternative of paper-based exams, but these will all be done online on a computer at this time. The vivas will be held in Auckland on the 9th and 10th of October, and in Melbourne the following weekend, 16th, 17th, 18th of October. So that's when the eligibility, we made a principled decision that those who applied for the May exam and therefore couldn't do it because it was cancelled at that time, will have first preference to this exam. And that's so that group will be given first preference. There will be almost certainly some capability for further candidates, certainly in the specialties with smaller numbers. They can often easily accommodate the relatively absolute number of small numbers that would come in through September. For the larger specialties, that's a real problem, particularly general surgery and orthopedics. So this exam, as planned in May, was the biggest ever, in fact, in terms of numbers for candidates, and so that already stretches those specialties with the larger numbers. And so if all the candidates who applied in May wish to go ahead and sit in September, October this time, there will be only very limited capacity to take more. So there will almost certainly be a second round of possible applications once we ascertain the numbers, and where there is capacity, there will be opportunity for those who wish to apply. And I guess just going on from the question, in those bigger specialties, particularly in some of the other medium-sized specialties, there'll be a limited capacity for extras, and in that case there will be very clear principles of who will get first preference. I know some of you have sent communications to me already and pointed out circumstances like if someone was on maternity leave in the first half of the year and they were planning to sit in the second and it was their last year of training, that sort of thing would obviously have high priority, and those perhaps in their last year of training will likely have more priority than those in an earlier stage in training. So there'll be those principles along those lines which we'll clearly enunciate and publish if it comes to triaging those for those extra spots.
Yeah. So I mean, I guess the obvious question, Phill, is why is there a limit? I mean, what are the logistical issues? Because I think a number of trainees and supervisors are struggling to understand why would there be a limit, given that we have a finite number attempting to sit this year.
So it's just really physical and examiner availability. So in those big exams, or those large courts, all examiners need to be on board to accommodate those big numbers. In the last few years, we've had that, and sometimes we recruit recently retired examiners to augment that, but that can only be done in a limited way safely. So it's really examiner numbers, and then it's also just venue capabilities. So certainly when all the exams were held within the hospitals or the availability of space, and this is now accentuated because of the distancing regulations for COVID, so we can no longer crowd people into spaces. So it will be those combination of examiner availability and just physical layout of the exam.
Right, and you did mention that the written exams will be online. What about the clinicals and the vivas? Are there any modifications to how they are going to be delivered?
Yes, so we've asked all the courts to look at how they could make the exam more COVID-proof, if you like, and many have risen to, they've all risen to that challenge, and particularly the two big courts which will have the most limiting effect if they couldn't go ahead, have altered their clinicals so that it no longer involves live patients in hospital, and that gives a great deal of protection against the sudden cancellation or an inability to go forward. There's been a number of other adaptations too to make the exam, if you like, more COVID-proof, including second venues which can be brought to the fore at a fairly short notice, so alternative from the Melbourne exam. And indeed, currently only 2 of the courts are planning to sit in New Zealand, and all the smaller courts will expect the candidates to come to Melbourne. But if Tasman travel is still a problem as approaching the exam, there is contingency plans to be able to examine those New Zealand candidates in New Zealand in all the specialties.
Okay, well, thanks, Phil. Niell, Boustred, I guess a follow-up question to that, and something Phill Carson alluded to, is that not all exam-ready candidates or trainees are going to be able to sit this year. So what are the training boards going to do to help support them, particularly if the training board feels that they should be in a training post next year?
Adrian, all the training boards are going to go out, will go out of their way to accommodate exam pending trainees. The boards are pretty much unanimously of the opinion that your best opportunity to pass the exam is if you are in a clinical training position, and there is flexibility in that regard. So certainly, as far as otolaryngology is concerned, we would keep anybody in a training position for 6 or 12 months, depending on the specific requirement.
Yeah,
we would be completely flexible.
Yeah, and my understanding is that training boards, certainly in principle, are trying to support exam pending trainees as much as possible. But I mean, there are pressures to get trainees through and to vacate positions so that selection can proceed. So I guess the training boards have also indicated that they will consider each trainee's situation on an individual basis to work out the level of support they actually need. Yeah. And Niell Price, talking about exams, we'll talk about specialty-specific exams. A number of specialties have examinations throughout their training program or during the training program, and this includes the clinical exam, but other writtens and vivas. What can you tell us about holding specialty-specific exams and clinical exams this year?
Yeah, I think it's related to the challenges that the fellowship exam faces, and that there are workarounds for written examinations, because we tend to do those in a disseminated fashion through the examination centres. But the viva exams and clinical exams are a big problem because at the moment they're not possible, and it's unclear as to when that will change. So there won't be a clinical exam offered this year. For those specialty boards that have that as a requirement for trainees in training, there will be no impediment to those trainees progressing for this year until the opportunity exists for them to sit at a later date. Each of the specialty training boards has got different in-training examinations, and each of the boards is making plans towards being able to offer those at certain times. So when the college is making availability for examinations in September, was it, for the fellowship written, and certainly later in the year for a GSSC for a written examination, the specialty boards will be looking to piggyback on those for the paper-based examinations that they need to offer this year.
Yeah,
but the basic principle will hold that if a trainee is unable to access an examination, there won't be any impediment to them progressing in their training pending the future ability to access that examination.
Right, thank you. So it seems from what you said, the clinical exam won't run this year. Now, my understanding is that that really only affects 2 set trainees, and I guess that's perhaps one of the key reasons why that won't be running this year. I have also been informed that the clinical exam will be run next year, and there will be 3 sittings to accommodate for any backlog. And so, and the early sitting will be in February, and there should be some scalability to ensure that any immediate backlog can be managed then. And the specialty specific exams, it seems that whether training boards will hold them or not, the college will support the provision of those exams if a training board chooses to hold them. And then you mentioned about the GSSC, and I guess I'll go back to Phill Carson about the generic surgical science exam. So we understand that this is an exam that's held in the pre-vocational space. It's part of the eligibility requirements for applicants to complete that before they can apply to set training. So when will the GSSC actually become available?
Yeah, so it's planned to run the GSSC in October or November this year. It is amenable to doing totally online, so plans are there to make it more, once again, COVID proof. So we expect most people who need to sit it should be able to access it towards the end of this year.
Yep. And yes, and in fact, the sitting of the GSSC is already exercises distancing because of the way the exam's run. So I don't think that's going to be the issue. I know that the GSSC, because of potential travel restrictions, I know that the exams department is looking at holding the GSSC in places in the major cities and perhaps also in Darwin, although the challenge for the college is identifying an appropriate venue that has the capability to actually maintain integrity of the exam. That's my understanding. Okay, so that's a bit about exams and fellowship exams and all. And as I said, there will be, as the information comes through, as we have been doing as a college, we've been posting that up on the website and informing trainees and supervisors. So we'll continue to do that. I thought we'd move on to the second theme, which is about in-training assessments. And this is certainly something that directly affects supervisors and trainers. So Niell Boustred, a common question we were asked by supervisors is how are we meant to assess trainees when there has been a reduction in their normal clinical work, including seeing patients and attending operating lists?
Well, I think there are a number of different approaches to this. I think one of the things when this all developed right in the beginning was that the college was keen to utilize this as an opportunity for innovation. So if one holds that thought in mind, things like telehealth consultations, which were new to most of us, provide an opportunity to assess other competencies outside of technical skills alone. So simple things like communication, leadership, management skills, health advocacy. I think one can still continue to assess those competencies. Then in terms of technical skills and operative opportunity, in otolaryngology, some of the jurisdictions that I have spoken to have indicated that the lesser demand on providing service has provided a better developed educational opportunity. So the highly selective nature of cases, and I guess I'm thinking particularly of head and neck and oncology, has provided a really excellent technical learning experience for people that are fortunate enough to be in those positions. And then I think the the question then is, well, what if I'm unable to get the necessary cases to fill or to meet requirements for my logbook? And I think, again, all the training boards are cognizant of this and will deal with these on a case-by-case basis, and will nevertheless have trainees maximizing the training opportunities, both in terms of numbers and specific opportunity as they go. And again, I think if people fail to meet these requirements, all the boards are acutely aware of the impact that COVID has had on the training program, and this will be taken into cognizance when trainees are considered for progression through their training.
I guess a fair question which someone has asked is relating to the operative numbers and operative cases. If we say that a training board is prepared to progress a trainee if they fall short on their operative cases, then into the future, what is the value of having numbers and maximum or minimum major cases, and how do we defend that as a college and as training boards?
I think that's a very good question. I think to some extent that numbers are not assessed on their own. It's part of the package of assessing a trainee's progression through training. They do give some indication obviously they give a good indication of exposure. I think logbook numbers also reflect on the position that the trainee is occupying, so the value of the actual training position that they're in. And I think we're all of the opinion that you need to do a certain number of cases in order to acquire competency in those surgical skills. So as an absolute measure of one's ability, one's confidence and one's competence in technical expertise, well, absolutely, they're not. But as an accessory to assessing your training, I think they're of value.
Right, okay. So, Stephanie, I might ask you this question then, because Niell outlined a number of the college competencies. How, as a supervisor, how are you going to be able to assess all the college competencies, not just the medical and technical expertise?
So I think there's lots of opportunity, and as Niell pointed out, we should be, I guess, maximising this opportunity where we don't get to focus on that technical side of things. And there's still workflow. There's still particularly emergency workflow where we've got trainees in the positions where they're seeing patients on consults on the ward or in the emergency department or in Cat 1 clinics, and they're still using their clinical judgment and medical expertise and making plans for these patients and also I think as well. Meetings like MDT meetings and compensating on the need to compensate for, I guess, the patient's dispositions and how to manage patients differently. And we're looking at the sort of, I guess, collaboration and teamwork. And, even for instance, if we're not looking at somebody's, if we had a period in Darwin where the consultant had to be the primary operator for any COVID suspect patients. So if we're not looking at the technical aspects of what that trainee is doing in that scenario, we still can be looking at the collaboration, teamwork, and how they manage, because that is a very fluid and environment where everyone needs to work together. So I think there's plenty of opportunity to look at all those, as well as still managing the ward rounds and leading the team and providing sort of education to junior staff and allied health and nursing staff. So there's still heaps of opportunities, and probably even more so, because we're taking the focus off that technical side of things. I guess I'll also do a bit of a plug here, being on the Indigenous Health Committee and raising awareness of the new 10th competency in cultural health and safety, or Indigenous health and safety, and the new e-learning that courses that are being developed, and the first one has been now released and uploaded onto the college website. So the first course is effectively ideally run over or, participated in over a 12-month period. So this kind of downtime can be used to I guess, improve in that area of competency as well. It's made up of a number of different modules, each about half an hour, but totaling about 10 hours that one should achieve over the year. So that's another area and another competency that we could be focusing on now.
Yeah. Well, I mean, thanks for that. And I guess I think from all our experiences, we recognise that whilst we may not be back to business as usual, there have been many opportunities that we can be interacting with our trainees, and in those interactions, there are certainly observable moments of their learning that we need to optimise on. I think that's what you were referring to, Steph. Niell Price, I'll shift to you. If in the current situation, one of the biggest concerns that supervisors and trainees have is that a trainee may fail to progress because of lack of clinical training opportunities, despite what we've just heard from Steph. So will trainees fail to progress?
Well, our expectation or our hope for our specialty board is that wouldn't be the case. But it may be for some trainees. Some units may experience such a catastrophic downturn in throughput or such a disruptive change to rostering that occurs. And in particular, I think the biggest risk we have really is trainees being stood down because of exposure risk. You know, those 2-week exposures and self-isolating could really add up if that were to become an issue. But by and large, we would echo what's already been said, is that the total number of cases and the total number of interactions may decrease, but the amount of supervision and interaction that occurs around them will almost certainly increase. That we're really seeing an increase in consultant input, consultant availability to support, supervise, train and assess around doing mini CXs and DOPs and all those other things, that actually we're probably seeing maximization of a smaller amount of training opportunity. I think other Niell referenced, talking about absolute numbers of logbooks, that some of the boards have gone way down a competency-based framework where we really don't have any particular number in mind in terms of majors and minors for per rotation or per total training. And even the boards that still have some numbers in mind have a more competency-based framework around that. We're looking at progression over time. That needs to be a gradual increase in primary operator rather than assistant. We need to see an increase in complexity over time. And we want to see trainees making the most of the opportunities that are given to them. But the absolute numbers from our board's perspective actually reflects more on the unit rather than the trainee. And that some of that data is actually, and we're going to come back to accreditation later on, but some of that data is actually more reflective on the training environment than the trainee and their personal progression through their training.
Yeah. And it seems that the COVID-19 situation is really testing our competency-based assessment processes and training processes. And by and large, I think every training board has accepted that relying on numbers of procedures or experiences is really not an appropriate way to be trying to determine whether a trainee will progress or not. And at the end of the day, if a training board believes that a trainee has not achieved what they are meant to achieve in this particular period of training, then there will be allowances made to extend their training without eating away at their maximum allowable time for training.
Yeah, absolutely. But we're seeing some really exciting things like Zoom tutorials, so that if departments have been split and half the team are being stood down on certain days, then they're available to participate in Zoom tutorials. And in the small specialties, we're seeing different training units linking up so that those Zoom tutorials can be conducted over different units. So it's actually been a very exciting development, and some things that we've reflected on for a while we could do are actually starting to come out of the woodwork.
So that's really talking to the scholar and teacher and the collaboration and management set of competencies. Stephanie, may I ask you, so we've talked about there are learning opportunities and assessment opportunities. We've talked about trainees will be progressing by and large. That's what we expect. but how would you rate a trainee's performance if you truly believe they are underperforming, irrespective of the reduced training opportunities from the COVID-related disruptions?
So I think, you know, we've all had underperforming trainees, and I think an underperforming trainee is an underperforming trainee regardless of whether COVID's here or not. And I think we need to just treat it simply as, not simply, sorry, but as an external factor. And you know, one of the first steps in managing an underperforming trainee is to explore, you know, in that non-confrontational manner, if there are any external factors that are significantly affecting the trainee's behaviour or participation, or I guess what level they're stepping up to. So I think that needs to be explored and recognised that I guess we all have responded differently, you know, from our own personal experiences, health or international relations or what have you, that COVID-19 has affected us all differently, and so some may be more affected, and that certainly needs to be taken into consideration. But again, you know, that those trainees who are being affected a bit more from the sort of psychosocial point of view about COVID-19, it should be addressed in a manner to support the trainee through that and to give them the best optimal, well, I guess the optimal situation to succeed. And I guess recognise as well that our relationships change during this time, and whether it be that we're spending more time doing those different, or you know, working on those different competencies or the non-technical competencies, and so kind of developing a different relationship, or maybe in some circumstances less time as supervisor and trainee together, and so less opportunity to explore those things. But yeah, I still think that all the usual processes should be followed, and the trainee given the opportunity to proceed or remediate.
Yeah, and of course, every trainee will be assessed individually by the training board, and to work out exactly what area they may be underperforming and how best to support them. So. And I think it's important to understand that my interactions with the training boards, I've learned that they're not going to make assumptions about why someone may be underperforming, particularly during this very stressful time. They will actually sit down with each trainee who is thought to be underperforming to identify how best to support that trainee. So thanks, Stephanie, and I think that's. I mean, we've covered a little bit about in-training assessments. I think it's probably time that we move on to the third theme, and the third theme is about set selection. And Julian, I've kept you quiet there, but I'd like you to address the question, which is, when will selection be conducted?
Thanks, Adrian. I'm not normally this silent this long, am I? But yeah, most people probably will know that selection for 2021 is now already open. It opened on the 20th of May. It's going to stay open until the 12th of June. That's 12 noon, Sydney, Melbourne time. Each board, though, are going to provide specific dates for the sequence that will happen thereafter. But the initial application window is the same, ending on the midday on the 12th of June. So at this point, all specialties have reopened selection, apart from cardiothoracic surgery that's still considering its position. But others are proceeding. The eligibility for the candidates who can register are those who applied in January. So many of you will remember that we opened registration, and then applications that followed, and then had to cancel applications at the 11th hour. So it's those candidates who originally registered who are allowed to apply. So in terms of the sort of process going forward, the timescales are going to be variable. I think and we've got quite a large window for interviews to take place. And I know a number of specialties, again, are trying to think of alternative ways to deliver interviews. as opposed to face-to-face interviews. I think that's the preferred option. I think the plan for most boards will be to do face-to-face interviews if they can, but there is some investigation into alternative methods, such as over online in methods such as this. But in terms of other modifications, it's certainly not changing the focus on what's going to be assessed. The method around multiple mini interviews and that sort of thinking and content, but it may well be that there's a slight change around how it's delivered, how the method of delivery. But again, each board will be providing more information around that as those decisions come about. And any contingency plans that need to be put in place. So we'll obviously endeavour to keep everybody informed. And I think if there's any doubt from any pre-vocational registrars that you may have in your workplace, I think it would always be good to check both with the college and with the specialty or specialties they're interested in applying to.
Yeah. Okay. So it will be run later this year. Cardiothoracic is still yet to announce whether it's feasible for them to run selection this year. And I guess you've identified that there may be some change in the way that selection is run, but the actual criteria and the content and whatever is normally looked at in selection will continue to be the same. I guess that's the same principle as with the fellowship exam. The standard is the same, the content will be the same, perhaps the delivery may be slightly different. So Phill Carson, may I ask you, will there be the usual number of vacant positions to appoint successful applicants to? We have a whole lot of people really anxious about that, including supervisors who are acting as referees for potential applicants.
So I guess this changes by the week, doesn't it? So just a few months ago, at the beginning of this COVID thing, it just looked like the whole to talk about pipeline, but it's sort of bad, but the whole pipeline might stop. There will be lack of progression due to lack of ability to sit exams and to train properly, and so it was potentially looking like a year that could be lost. I think things have changed a lot since then, and as we've just discussed, where there's a very high chance the fellowship exam will go through and people will progress. We've talked about the intent and the likelihood of all the trainees going through. So indeed there will be, we believe, lots of vacancies for new trainees to come in. It will vary though, and it's probably in some, it may be slightly less than usual because of all those reasons we've discussed, of people not being able to exit the training scheme at the other end, but it looks very hopeful that there will be a good number of positions. And of course, that's no different than any other year. It's only last year, I think, Niell Pricing, that paediatrics didn't take any trainees because the bases were all full, and that was with no COVID around. And this year, and the bases are opening up. So for your particular specialty, and that will be the same in all specialties, I think. And so it goes back to, I guess, your supervisors. What do you advise these surgical aspirants to do? And it would, I think, would say that this year there's, there wouldn't be a huge disadvantage this year to apply, and certainly if people don't apply this year and all apply next year, there will obviously be a bulge in applicants even if there's a few more positions. So either way, there's no guarantees either way, but I would think the number of positions open will make it still very worthwhile for the good quality candidates will still have a good chance of being appointed.
I guess one of the dilemmas, Phill, is that a number of training boards, not all, but a number of training boards do have maximum allowable attempts to apply for set selection. And will this year's set selection count towards that allowable maximum number?
Yes. So unfortunately, I can't give you a definite answer at this stage, and it would have been nice to do that. But those boards who have limits on the number of attempts are considering that. There's a in line with our general principles that COVID will not disadvantage candidates. They're listing very much to that, and so I would imagine if well, I guess the principle will be if there's a fairly normal number of training places available, that they go on as normal, but there is the potential that this particular round will be not counted towards maximum attempts if there is a significant constriction in numbers of available places. So yeah, it would be nice to give some assurity for you to give to your surgical aspirants around about that, but I can just say going back to the principles is they will not be greatly disadvantaged if COVID well, if they look like they're going to be disadvantaged because of these particular circumstances, that will be minimised to the extent possible.
Yeah, and
it's a very politician's answer to it, I know.
So hopefully we'll have a definite answer to that question very soon. I don't think applicants will need to wait too long to get that response, because I think training boards are trying to bring some degree of certainty as much as they can to those who are applying for set selection. I'd like to move on to another theme. This is about supporting.
Adrian, Julian's got his hand up.
I just wanted to add, I know there's been some concern around late appointments, obviously with selection running roughly 2 months behind when we would normally do it. I just wanted to say that the college has written to all jurisdictions to raise this, because probably appointments would be made from the middle of October, possibly through to the very end of November. And we've had a supportive response so far across the jurisdictions of both countries. So just to say that you can reassure Prevox that the system, as it were, is aware of the issue and supportive of it.
Yeah, and that's actually reminded me, Julian, that the college has also written to the chief medical officers about seeking exemption for travel at the changeover. So we have a rotation changeover coming up in a couple of months, and we're looking at seeing whether we can get some exemptions there for people who have to cross borders for themselves and their families, and we won't get a response to that for another couple of weeks. So moving on to supporting pre-vocational doctors, Niell Boustred, how will pre-vocational doctors meet their minimum eligibility requirements for selection next year, given that there's been significant disruptions to things such as face-to-face courses, conferences, even in their own clinical rotations, they've been shortened or they've been redeployed. So a number of these activities and experiences would have been part of minimum eligibility requirements. How are they going to meet that?
Well, Adrian, I think if you think back on the discussion tonight, it's all been about innovation, flexibility, bespoke processes, no hard and fast rules, and awareness around how COVID has impacted all of the groups of doctors that are involved in surgical training schemes. And so selections for 2022 will be no different. And I certainly no hard and fast decisions have been taken as yet, and there's no pressure on those decisions to be taken just yet. But due consideration will be given to the fact that rotations have been adversely affected. Certainly in New South Wales, the JMOs have not rotated, and that may well have affected people's ability to get to meet minimum criteria or meet eligibility criteria, and certainly may have affected them to occupy roles that would have given more favorable CV scores in their applications. So I think we're all very aware of the impact of COVID on the JDocs and pre-vocational on the pre-vocational trainees, and we'll look at this in the months that lie ahead and make decisions in line with the sense of flexibility and understanding and giving due consideration to the situation that we've come through.
Yes, and I think training boards are acutely aware, as you said, and they're not going to require anything which is unreasonable given the current situation, and perhaps this situation which will be going into the foreseeable future. Stephanie, may I ask you, how can we support pre-vocational doctors develop their competencies ahead of any selection, given the current situation?
I think we can do what we've always done and use the JDoc framework and follow that, and review their knowledge and their skills, and look at what level they're up to, and ensure that they continue to progress along those levels, and also develop their professional profile. So looking at their sort of workplace assessments, achievements, experiences, maintaining their logbooks. Although this is obviously going to be an area that I guess won't progress during this time. Yeah. Okay,
yeah. And for those who are not familiar, but the college runs a JDocs website, which is specifically targeted at pre-vocational junior doctors. And that's a significant resource for junior doctors in terms of identifying competencies and learning opportunities, and also acts as a guide for developing those particular competencies in that pre-vocational time, and allows junior doctors to also record their learning experience. So we'll put the link up to that website shortly. Look, I might, yes, Niell?
Sorry, I just echo that over recent years, the Court of Examiners has been quite vocal to encourage supervisors and mentors not to prepare the trainees for the exam that they sat, but to take steps to prepare them for the exam as it exists today. And yes. I would just echo that for selection as well, that the boards have moved the selection goalposts, if you want to sound negative, but we are looking for different things and applicants now than they did when we all got on to training. So for our supervisors and surgeons who are acting as mentors for people in that pre-vocational space, it's very important, I think, to try and keep up abreast and in contact with what the expectations are today, for how to advise people for how they should be preparing themselves for selection.
Yeah, and certainly I'd be encouraging all our junior doctors to document and record their experiences, particularly during this disrupted time. I know a lot of my junior doctors are doing a huge amount more teaching and online, and some very innovative educational practices, and how they manage their time and disruptions are actually quite important reflections of their competency. So getting them to document that would be good. Look, because of time, we're going to move on to accreditation, and Niell Price. So will lower operative numbers and clinical training activities for a unit disrupt or jeopardize their accreditation status?
I would imagine that would not be the case. I know accreditation is a vexed process, and there is an experience in the centres that somehow punitive, but it might be surprising to learn that the training boards definitely don't want to unaccredit posts. We've got trainees that we need places for, and we're doing everything possible to keep places accredited. There's not going to be scope for accreditation visits this year until the college as a whole opens up travel and face-to-face meetings. We're not going to be able to do accreditation visits, so it's been an understanding that accreditation will be rolled over, that there'll be, if anything was falling due this year, it will automatically fall due next year. And I think each of the boards will develop their own strategy, but I would imagine we will try to not look at volume-based data that arose from the COVID affected times, that we'll want to know what centres do year in, year out, not what happened to them this year.
Yeah. I think the accreditation, even though we put that on hold, I think the decision recently is that training boards can start to liaise with the hospitals, and as long as undertaking an accreditation does not distract or disrupt the hospital's focus on patient care, then it may be able to proceed this year in some cases. Yeah. thanks for that, Niell. And regarding accreditation, Julian, and I guess this is more about supervisors maintaining their professional development, which is tied into the supervisor role, but also tied into an accredited post that is required. How will a supervisor actually meet their professional development, which is part of their role of being a supervisor?
So Adrian, it builds, I hope on the approach here builds on the approach that we're taking across the piece really, which is that, you know, that there is an understanding that it's difficult at the moment, obviously with a number of courses and other activities cancelled. And so we are saying that, you know, an extension will be granted to all supervisors in terms of their PD requirements. So no one will be disadvantaged, as it were, for the language we use around trainees. It's exactly the same. No one will be disadvantaged around disruption caused by cancellation of courses and events. On that, we're working hard to get these courses back up and running. We're going to be focusing on the mandatory courses, particularly for trainees, and we hope to get those up in the coming months. So hopefully this will start to also be supportive for supervisors as well.
Okay, thanks. Now, before I go on to an update on a number of activities that the college is doing, I did see a question on the panel, and this is directed to you, Phill Carson, and it relates to final year trainees who pass the exam, and particularly about I guess new fellows taking on fellowship posts, because a number of the specialty societies in Australia and New Zealand who run special post-fellowship training programs may not be running them for the same reason that we've had to put college training on hold in some aspects. So I guess that's a comment, but do you have a particular view about you know, meeting that challenge, that we can put out graduates but they may not have positions to go on to either consolidate their training or to further their training before they take up a consultant position?
It certainly is a disruptive time, isn't it? And certainly that whole out of the end and long planned fellowships overseas and stuff are likely to fall through, let alone these local subspecialty areas. However, overall, there's going to be a good amount of work to do, and in fact potentially even more work next year as we try to catch up on this you know, lull in elective surgery. And the number of funded positions around the country are going to stay the same, so it may just be different designations, but I don't think there's going to be people out of a job. Some overseas people who come to Australia for fellowships perhaps won't be able to come in the same way that some of ours may not be able to go overseas, and that should all cancel out, I think. So even though it's going to be anxiety provoking and disappointing for some, I don't anticipate any great deal of unemployment in the sense that most people who do want to do a year or two post fellowship of extra experience will still get that, but perhaps in not their first choice, or not in a post. So these you know, for instance, they have patobiliary or upper GI training posts. If they haven't got a designated trainee, they'll still want somebody there to do the work. And like we said in the earlier thing, I think if people go into that with a mind and attitude full of learning, they'll still benefit greatly in those posts and certainly become more confident and mature surgeons, which is often the aim in those early post-fellowship years.
Thank you, Phill. And before we leave the topic of accreditation, I've just noticed a question to you, Niell Price, and this is about hoping that at least in this year, we will continue to look at trainee evaluation of the training posts, that we're not going to just put that on halt. Is that correct?
Yeah, absolutely. You know, just as we want to evaluate the trainees, we want to continue to evaluate the training posts. We need to know that good quality training is still occurring, and where the areas that can be improved upon.
Yep.
Just a comment on that, Adrian. I mean, in many ways, this disruption actually allows training posts to show to shine in many ways, doesn't it? And so even though the numbers might be down, if trainee experience, we hope, will be not diminished and perhaps even enhanced for all the reasons we just said about more time to concentrate on training and training experiences. So I don't think it's we hope that good will come out of it rather than just a general decrease in the quality of training.
No, I think you're absolutely right. Just as the COVID disruptions have challenged our training programs and our processes and ability to deliver training, I think it's challenging units on their ability to supervise and train. So shall we move on to an update on a number of key projects that the college has been embarking on? Julian Archer, are you able to give us some insights into some ongoing projects around supervisor support and recognition?
Certainly, Adrian. We've got three that we thought we might mention. I was going to speak to the first one, and I'll hand over to Phil for the other two. We didn't want to miss the opportunity to give an update around a really big, important, really set of projects looking at better supporting supervisors. So this is a project that's been endorsed by BSET and by the Education Board, basically to look at how we better support, recognise and value the important role that all of you play as supervisors of training. And the college is very conscious that it's a pro bono role, and it is absolutely central to the delivery of RACS training programs. And it's regularly highlighted by the regulator, the AMC and MCNZ, obviously around the central importance of supervisors. So we've got a four sort of streamed project going on at the moment, which is looking about how we better advocate for supervisors. We're very conscious that some of you might even have, at least on paper, dedicated time to support your trainees, but that doesn't always translate into reality, and many of you won't even have it on paper. So it's how we better advocate, and we're looking at trying to do that at the highest levels across the healthcare systems in Australia and New Zealand. We're wanting to look at better ways to recognise and value the role that supervisors undertake, and looking at better ways of how we do that. You know, I don't think this is additional money in pockets, but looking at better ways of recognising and valuing the really important role through the college as well as through the employer. The third part is around supporting supervisors in two ways. One is about identifying competencies. I'm sure everyone's aware that there is a RACS standards for supervisors, but we've never mapped out the competencies. So in other words, the expectations, as it were, for supervisors to give a better, clear guidance, particularly to new supervisors, about what is expected of them and how they might go through their journey as a supervisor. That's a piece of work we've been doing most recently, and I want to thank so many of you. Many of you on this will have filled out a questionnaire or undertaken an interview in the last 4 to 6 months, and I'm very grateful to so many of you. We had a really good response, particularly to the survey, so thank you. And then the last bit is about once we've mapped out and clearly got an understanding of what's required, then how do we best support it? We do have, of course, a number of courses and resources for supervisors, but actually we've never mapped those out properly and said, how do they really support the role? And most importantly, are there any gaps in the way in which we support the role? And so that's another piece of work in the fourth stream, sorry, to help supervisors. So advocacy, recognition and valuing, identifying the competencies, and then developing resources to support supervisors better in those competencies. So again, thank you for people's involvement in that to date.
Thank you, Julian. We'll keep people posted as as those projects progress. And Phill Carson, update on a couple of activities as well from you.
Okay. Yeah, so just going on from what Julian said, I mean, for years we've just assumed that surgeons are natural, or assumed, I guess we haven't supported this teaching and education part of surgery as much as we could have. And the same goes for governance of teaching. So your work in your local training board and in the national training boards, and we've just we've gone into it as expert surgeons, as often good educators, but when it comes to governance and legal knowledge and administrative knowledge, we often learn by practice, and that can lead to some poor outcomes. So there's a project going at the moment to support training boards in all those things, in governance, in administrative procedure, and in legal ramifications for decisions. And so all your local training boards, their heads are part of the national training boards, and they will be getting this sort of insight and education, and I'll bring it back to you as supervisors locally. And that will be an ongoing project, and we trust that out of that there'll be better outcomes for trainees, first of all, because boards will be making, supervisors and boards will be making better decisions, better experience for trainees, but also increased safety and confidence in you, especially in this very fraught area of giving feedback and then being accused of bullying and all that sort of fears of that sometimes come along with all the good sides of being a supervisor. And lastly, I guess the bit Julian was saying about the about protecting time for supervisor, we're going to add that to the accreditation process. And the other thing in the accreditation process we've been looking at is to actually get all those general things about any training site mapped out, so that every time a training board comes to accredit your post, your hospital, you won't have to look at all those things, library access, be it, bullying and harassment policies, etc. That will all be there, all those common things. And so the assessment, the accreditation process will be easier, certainly for your administrative colleagues in the hospitals and you as departments of surgery too. You just look at the more specific, specialty-specific aspects. So we just really appreciate this. I think someone just said, no, as Julian just said, supervisors are the pillars of the training scheme, the incredibly important part of holding the whole thing up, and the college recognises that. It was always recognised that, but now we're putting a lot of practical effort and time into actually supporting you and your training boards to get this right.
Well, thank you, Phil. And on that very acknowledging and positive note, we do need to close off on this webinar. We have run out of time. So thank you to all the panelists, to Stephanie Weidlich, who unfortunately we cannot see, but thank you for your involvement, to Phil, to Julian, to Niell Price and Niell Boustred. Thank you very much. I should also acknowledge Grace Chan and Emma Shields in the background, our college education staff, who professional development staff who've been keeping things running. A reminder that next Wednesday evening, Debbie Poltridge, the college educator, will be facilitating a webinar on modifying teaching and supervision during COVID-19. So it seems very appropriate to this current era that we're in. So please stay safe and healthy, and please keep up the good work. We truly value the input of supervisors and trainees, trainers, I should say. And as more information comes through throughout this particular period, we will keep you informed. So have a good evening, and thank you very much for attending.
See ya.
Good night.